Professor Paul Symonds has come in today to give us the benefit of his long, extensive experience of treating cancers, and I think the viewers will be very interested to hear what you have to say about some of the basics and some of the misunderstandings that have grown up around cancer, because cancer's the most common, most feared condition in the general population, but views of cancer differ widely. Let's start with the basics if we can and talk about the concept of cancer. For those that, we hear that word all the time, but what is cancer really in biological terms?
Cancer's a disease of cells. A structure such as skin is made up of individual cells that divide in a planned fashion. When you get a cancer, the cell division is unplanned and it's excessive. This makes a mass which we call a tumour that can press on or block things, and also these cancer cells can spread around the body and form tumours elsewhere that can disrupt the way things work, like if they settle in the brain, they can cause paralysis, headaches, etc.
Now, there's a lot of recognition at the moment of cancer, and that's right, of course. We want to make sure we're detecting and treating cancer appropriately. Do you think the rate of cancer in the population has changed at all?
Well, the rate of cancer in the population has changed because the population is ageing, and cancer is essentially a disease of older people. For instance, at the LRI, the average age of patients we see with cancer is 66. So as we get more and more old people in the population, inevitably we're going to see more cancer.
Now, what about individual cancers? I mean, there's variation there, isn't there, in terms of how individual cancers have changed over time. Does that reflect environmental change, for example, smoking rates or other factors?
Well, it certainly affects smoking rates. When I started in oncology, it was in Glasgow, and in those days we saw 6 men for every woman who had lung cancer. By the time I left Glasgow, we were seeing roughly the same number of men and women, and in the East End of Glasgow, more women, because in fact, paradoxically, more women these days are smoking. In Leicester, we tend to see increasingly more Asian men with lung cancer rather than British white men, because more Asians smoke.
So what are the more common types of cancer?
Well, in women, the most important cancer is breast cancer. It's estimated as high as 1 in 10 women will actually develop breast cancer in their lifetime, and it's worth saying that a lot of women develop breast cancer older than 70. At least a third of breast cancer cases are older than 70. But breast cancer has been a real success story. When I started in oncology, only less than half of women with operable breast cancer survive 10 years. It's now 90%. There's been a huge advance in the survival for breast cancer, and equally there's much less mutilating surgery. Mastectomy is a minority operation. Most women have breast conserving surgery these days.
So breast cancer is rightly well known in the population. You mentioned about changes over time. Now, breast cancer is one of those cancers where there is a surveillance program, a screening program. Do you think that's affected the prognosis, or what's the importance of those screening programs?
Well, it's highly controversial. The screening program, as well as picking up cancer, also picks up pre-cancer, and some of those pre-cancers would never turn into the real thing. And there's been considerable argument about the value of breast screening because it can do some harm as well as good. Many authorities, though, feel the value of screening has been overplayed. It is important, but the large 40% or so increase in 10-year survival is due to advances in treatment rather than screening.
Did you ever work at a time when there wasn't a screening program for certain cancers, and then
yes.
Did you notice that change come in?
Oh yes, breast cancer for a start, but the biggest change is cervix cancer. I used to work in Glasgow, which was the highest incidence of cervix cancer in the UK, and we used to regularly see 350 new cases of cervix a year. And when the screening program kicked in, by the time I was leaving Glasgow, it was down to 150 new cases a year, and the incidence has declined since then. the cervical screening program has been a great success story.
So if I understand correctly, the pre-cancerous change is being picked up and treated, and then it's not evolving so far and presenting late with
Absolutely. Screening is designed to pick up precancerous change and treat it. And the interesting thing is that the incidence of precancerous change when the screening program was introduced was increasing markedly, caused by the human papillomavirus, which is the cause of cervical cancer. And if we hadn't had the screening campaign, it's possible that we could have similar levels of cervix cancer as in Russia. And Russia has 10 times the amount of cervix cancer that we have. They have no screening program.
See, that's interesting because, you know, from a screening perspective, sometimes secondary services think if a screening program is rolled out, we're going to get lots of the condition detected. But where the condition presents anyway, at some stage, that's not necessarily the case. The reverse pattern is perhaps the case, that the screening picks up earlier stages, which then can go into treatment. Is that right?
I think the main thing that the cervix screening program is aimed for is pre-cancer. It does pick up some early cases, but the main thing is it stops pre-cancer turning into cancer. That's its important thing. It's very interesting, the Republic of Ireland. Dublin is rather like Glasgow when I started 30 years ago. They see 400 or something new cases of cancer in the Republic of Ireland because the Republic's got no screening campaign. It's worse in Eastern Europe. And it's interesting that we're seeing more and more Polish patients in Leicester with the Polish immigrants coming through because Poland has no screening program and a higher incidence of cervix cancer than this country.
That introduces another interesting question about national differences or ethnicity differences, which are not related to organizational structural change like screening, but some other population endemic factors or genetic factors. Well, what are the main influences of ethnicity on cancer?
Well, you certainly see different cancers in different populations. For instance, the Japanese typically suffer from a higher incidence of cancer of the gullet, the esophagus and stomach than this country. The most interesting cancer, as far as I'm concerned, is a rare cancer in this country called Nasopharynx that begins in the space behind the nose. Rare in Britain, 200 new cases. In Hong Kong, thousands. And this is genetic. We know that this cancer is caused by a virus called the EB virus, and people in Hong Kong seem particularly genetically susceptible for developing this viral induced tumour.
Now there are also, I know you've been involved in some work on the complications of cancer, psychological and emotional, in relation to ethnicity. What's your latest findings in that area?
Well, our latest findings are extremely important. In Leicester, we found among British South Asian people double the incidence of anxiety and depression, significant anxiety and depression compared to white people, and worse than that, 5 times the incidence of severe depression. Now, we wouldn't tolerate a group of cancer patients who have twice the amount of pain than another, but we're actually tolerating a group of cancer patients who have twice as much emotional pain as others, and we really must do something about this.
I mean, it's gratifying to hear that coming from an oncologist. You know, you're interested in the emotional well-being of patients. Somewhat controversially, do you think that view is shared by all of your colleagues? Do you think there's some room to improve there?
Oh, increasingly so. Like, the practice oncology has changed enormously during my career. When I started, there was a great reluctance to tell patients the diagnosis unless they directly asked. And people talked about euphemisms like a blockage in the tube going into the lung or an ulcer on the cervix, and so on. And when I went to the United States, to Philadelphia, it was a culture shock because they give the diagnosis often brutally, you know, it's leukemia, son. And when I came back to Britain, I started as a consultant, and in my first 6 months I was marched into 3 senior consultants' offices and told off for doing this. That's a big change. Equally, 20 or so years ago, we were just interested in getting people to survive. Now we more worry about things like emotion, distress, anxiety and depression, which perhaps 15 years ago we didn't. And I think it's partially because of the success of cancer treatment, we're curing more people, and we're now worrying about other aspects of the cancer illness. because the emotional aspect of the cancer illness is terribly important.
Do you think partly that's because of the improvements in survival overall? Patients are often living with their cancer for many, many years. One statistic I've read recently is that 1/3 of patients will die of another condition, not a cancer. I don't know if you'd agree with that.
That's certainly true. Like if one takes prostate cancer, a very significant number of men will die with prostate cancer, not from prostate cancer, because it develops in men classically. Our average age is 72, and we can often eliminate or control prostate cancer, and the man may die 85, 86, say, of heart disease with prostate cancer, but not from prostate cancer. With chronic disease, the biggest difference I've personally seen is with cancer of the ovary. When I started, by and large, cancer of ovary wiped women out within 6 months. Now we have a considerable number of people living with ovary cancer longer than 5 years, because we give them drug treatment, they do well for a couple of years, the disease relapses, we give them more drug treatment, they do well, and ovarian cancer especially has been translated into a chronic illness.
Now, this chronic illness model of cancer is very interesting, because we obviously do need to attend to quality of care issues during that period. But it's also interesting to unpick what's lying behind that improvement in mortality. Some of it may be screening, but screening you've already talked about and only applies to certain cancers anyway, from a population point of view. What are the real innovations you've seen, in treatment over the last few decades?
Okay, let's take breast cancer. Overall, we've seen an improvement of 40% absolute survival improvement. And this is partially due to improvements in screening, improvements in the type of surgery, radiotherapy, chemotherapy, and especially drug treatment. The biggest component is a very cheap drug called tamoxifen. Say each of those components have improved things by 5%. When you add them all up, you've got 8 times 5, 40%. And it's often been a team effort, and it's been different treatment modalities rather than one that's brought about the improvement. One of the biggest improvements we've seen is prostate cancer. Although prostate cancer is more common than it used to be, since 1988, prostate cancer deaths, people writing death from prostate cancer on the death certificate, have been halved. And this is partially because of better hormone treatment, better surgery, better radiotherapy.
You mentioned 2 treatments there which are hormonally based, but there are a lot of other chemotherapy agents who work through complex mechanisms. Just from the perspective of chemotherapy, if somebody's facing chemotherapy, what basically is chemotherapy, and what are they actually facing in terms of their treatment burden?
Well, the first thing is to say the side effects of chemotherapy vary enormously between different drugs and different regimens. Chemotherapy is used 2 ways. The first is as a curative medium, and a common situation is in breast cancer following surgery or radiotherapy, because it's known to increase the chance of cure. It is also used, though, to help symptoms, particularly say in lung cancer, where it can make people feel a lot better. Ovary cancer is a typical example. If you can actually stop fluid forming in someone's tummy, shrink the mass of tumour, the patient feels much better. Some chemotherapy agents cause hair loss, others don't. And it's important not to generalise. The care of patients with chemotherapy has improved enormously. For instance, the anti-sickness drugs are millions of times better than when I first started. In the vast majority of cases, we can stop anyone having nausea and vomiting, which we couldn't 30 years ago.
Why is it that sickness is such a common side effect of chemotherapy?
I don't know. The chemotherapy obviously goes to the vomiting centres in the brain and triggers off the vomiting centre, but why? And why some drugs cause vomiting and others don't is an open question.
What's a typical course of chemotherapy?
A typical course of chemotherapy is often 6 pulses of chemotherapy given at 3-weekly intervals. But some of the newer drugs, some of the biological drugs like Herceptin, sometimes are continued for a year.
Now, some patients come in for their chemotherapy and it's intravenous. Others are having a tablet-based form. Why the difference there?
It's how you can get the drug in. If the drug can't be absorbed from the stomach, or the bowel, we've got to put it into a vein. If it can be absorbed adequately from the stomach, clearly we'd prefer to use a tablet.
Now, when people start chemotherapy, often side effects do develop, and I know you try your best to control them. But how important is it that the patient completes their course, particularly every session? I mean, are occasional omissions allowable? Because people are worried about whether they can skip occasional sessions if they need to because they are too unwell.
Well, can I say that if they have an extra week, say, in their schedule of chemotherapy, it probably won't make a lot of difference. But if it's, say, something like treating with curative intent with breast cancer, we know from experience it's important, firstly, to get an adequate dosage of the drug in, and secondly, get the full 6 courses. We do know from the earlier days it does improve long-term survival.
You mentioned the word curative intent, which essentially means you aim to make that cancer go into remission, isn't it?
Correct.
How much can you say that the cancer has disappeared? Because this is really the big question when people are undergoing treatments. They sometimes misunderstand whether the cancer is gone altogether or are they still at high risk of recurrence, and what is the risk? And these are all complex questions, and I know there's a lot of individual variation, but just in broad terms, what could you say about that?
This is a difficult point because our most sensitive CT scanners can see a tumour, say, 5 millimetres in size, but 5 millimetres actually contains quite a lot of cancer cells. So to a certain extent, we can say to the patient that we can't detect any cancer on examination or by scanning or using blood tests. And to a certain extent, we've got to go on experience by saying, what do you think your chances are? And I can say to a patient, at this moment in time, our experience is that you have, say, a 30% risk of the cancer coming back and a 70% chance it won't. And this is partially based on experience and partially based by the fact we can find no cancer. But we're giving the patient rather uncertain information. We're saying, yeah, 70% chance you're cured, but a 30% chance it could come back. And that's the best at present we can do.
I notice in other medical specialties, well, the one that springs to mind is epilepsy. I've heard the neurologists look up in tables the likelihood of a further fit occurring after one, depending on the risk factors, and they seem to give quite exacting estimates of prognosis. Now, clearly they're based on, in many cases, large studies. Do you think we're going to get to the point where the prognosis estimates in cancer across all types can be accurate, or will there always be some significant variation, meaning that we can be wrong when we try and give those estimates?
Well, no, we're high-class bookmakers. In fact, with due respect to neurologists, so are they by giving odds.
Yes.
But there are, for instance, some very sophisticated databases now where you can work out the risk of patient's tumour coming back, and there's computerised programs. In breast cancer, the best probably currently is called Predict, based in Cambridge, with results of women treated in East Anglia, and you can, in the computer, type in the various factors and say to a woman, you have an 86.5% chance of being tumour-free in 10 years. This is the sort of thing that Predict will give you. There's other databases, particularly some of the American databases for colon cancer and malignant melanoma. Colon cancer's got over 100,000 patients in it. So you can look this data up. Some of the data I carry in my head from personal experience. And I know from experience, say, with our treatment of cervix cancer, I can actually quote from our own analysis and say, this is your chance.
And I'm sure people really appreciate their own oncologist whom they trust giving a more tailored estimate for them that's more personalised, because you can take into account the individual differences, can't you? But the big picture here is actually whether giving those estimates in the current time with the current degree of accuracy is useful and beneficial to patients. Because I know patients often vary themselves in how much they want to know.
Precisely.
Some don't actually want to be told in black and white terms. And particularly if the news isn't the one they were hoping for, they sometimes psychologically it can be better to be hoping for the best rather than have the person that you trust say that's not going to happen.
I think this is very important. I think when we talk to patients, there's a number of ways you can approach this. The first is the obvious question is that I can give you a percentage figure, do you want it? And then I can say, well, your chance of cure is not good. That's a shot across the bows. because I may say, you've only got a 15% chance of being cured. Say a rather nasty brain tumour, that may be the situation. Equally, I can say, your chance of cure is good, would you like to know a figure? I tend to give figures more, say, around bookmakers as a form of odds, because actually people understand odds better than percentages. Rather than saying 66% chance of cure, you can say you have 2 chances out of 3 of cure. And people understand that better.
Well, that's fair enough. Let's move on to radiotherapy. We haven't spoken about radiotherapy. Radiotherapy is another big arm of cancer treatment, along with chemotherapy and surgery in broad terms. What is radiotherapy?
Well, the first thing is worth mentioning, the contribution of radiotherapy towards the cure of cancer. The cancer czar Mike Richards has estimated currently that more than 50% of cancer patients are cured. Half of those cures come from surgery, 39% from radiotherapy, and 11% from chemotherapy. And after surgery, radiotherapy is the most important curative medium. In Leicester, we use very high energy X-rays to treat the cancer, destroy the cancer without doing damage to the normal tissue around it. And we use large X-ray generating machines called linear accelerators to do this, and they deliver the treatment extremely precisely to millimetric accuracy. And we can focus the X-ray beams much more accurately on the tumour. Our neurolinear accelerators even have CT scanners built into the head, so we can check we're hitting the tumour each time.
I'm assuming the radiotherapy will kill any cell that it's targeted at for a significant period. Is it a case of the targeting being the key thing?
I think the first thing is the targeting is the key thing. It's very important that you must hit the whole tumour. The second thing is you've got to give an adequate dose to kill the tumour, but you've also got to protect the normal tissues around it. It's useless killing the tumour, say a breast cancer, and leaving a woman with a scarred, painful breast for the rest of her life.
When is radiotherapy used and most effective?
More than 50% of people with a cancer illness will get radiotherapy during their cancer illness. We use it in 2 ways. In the Leicester Royal Infirmary, about 2/3 of our patients are treated with curative intent. About 1/3 are treated what we call palliatively, which means the aim of the treatment is to improve quality of life. The intensity of the radiotherapy may vary very markedly. For instance, a man with prostate cancer may get 37 treatments over 7.5 weeks. Someone with a bone secondary from lung cancer may only get a single X-ray treatment, but a single X-ray treatment has a good chance of getting rid of that man's pain from his secondary in the bone.
People still are sometimes confused as to why they see a patient who seems to have a relatively similar condition having treatment X and they don't necessarily receive it. Sometimes they can feel they're missing out.
I think one has got to take into account lots of things as well as the cancer, what other diseases the patient suffers from and their illness. For instance, if we go back to prostate cancer, we know that a mixture of hormone treatment and radiotherapy treatment can give very good 10-year survival. But seeing this as a disease of elderly men, some men may not going to survive 10 years, and they're far better off getting hormone treatment alone or whatever. And we've got to try and tailor-make the treatment to the person, taking into account their age and any other medical condition, as well as the cancer.
What have the advances been in the radiotherapy field in the last 10 years?
They've been enormous. A dozen years ago, whenever we treated a tumour, we used squares or rectangles to project the X-rays onto the patient, and our so-called plan volumes were either cubes or definitely geometric shapes. Now we're able to shape the X-ray beam in any shape you like around the tumour, and we can adjust the X-ray beams far more to produce shaped volumes, which we couldn't do 10 years ago. And we can easier avoid things like bowel, which by treating bowel you can cause nausea, vomiting and diarrhea, and we can reduce the dose of bowel. These are technically much more demanding. An old-fashioned prostate cancer treatment I could plan in about 10 minutes. It now takes me an hour and a half to 2 hours, and I'm faster than most to plan these treatments because they're much more complex.
What is involved in the planning, in brief? Is it the targeting areas?
Precisely. You've got to actually delineate the target. And we may need a lot of things like CT scans and MRI scans or bone scans beforehand, tell us where the target is. We often do a CT scan as part of our treatment planning, and we use those images on the CT scan, taking into account other scans as well, to plan exactly where we treat, not only where the tumour is, but where other vulnerable tissue is, like bowel, that we want to avoid.
Do you think the oncologist has a key role there? The only reason I say that is it strikes me as an area which could be automated. The matching of the size of the lesion to the delivery of the radiotherapy, couldn't a computer ally those two exactly?
Well, no one's done it yet. And what we need to do is often say on a CT scan, you take it slice by slice, and we carefully mark where we think the treatment should go, which organ we treat, and equally we mark our jargon, organs at risk, areas we don't want to treat, and then we bring in our physics colleagues and also perhaps the radiographers. Treatment planning is a team effort, and discuss the best way to treat this patient. The physicists do up the calculations, but with regard to marking the target volume, there isn't a computer yet that can replace a human being for doing this. Who knows in the future, but not at present.
Okay. Let's briefly talk about the third big modality, surgery. I know that's not your core field, but just in your experience, what's the role of surgery in the treatment of cancer?
Well, surgery is vital. Firstly, surgery often gives the diagnosis. It's the surgeons who often do biopsies or whatever. Surgery is still an important curative medium. For all the advances in radiotherapy and chemotherapy in the treatment of breast cancer, surgery is still vital. Surgery may have a role in a palliative setting. For instance, someone with incurable cancer who develops bowel obstruction, the surgeon may be able to relieve that bowel obstruction. It's still a vital treatment. It's a treatment that's become more refined. Deaths from surgery, cancer surgery, are much less common than they were when I started. The surgeons are very good at judging, is the patient fit enough or not for surgery, and that's a very important question.
Have there been developments in the surgery field that you're aware of that impact upon the patient's well-being who has cancer?
Oh, well, the obvious thing again is breast cancer. When I started in this game, the vast majority of women had their breast off as the treatment, and that's just not so now. The vast majority of women have breast-conserving surgery, and the people at Glenfield have taken it further forward in that in those who they have to do a mastectomy, they can do things like immediate or delayed breast reconstruction. And the breast surgeons have gone now into reconstructive surgery big time when they have to do a mastectomy.
Thinking about the holistic care of the patient, who are the key team members who you would work with on a daily or weekly basis that improve the overall care of patients?
Well, the first person I would think about is the nurse, and I think the roles of nurses are unchanged. The best nurses are great carers and very good at psychological support of patients, often form a great empathy with them, have tremendous judgment about the patient's ability to withstand treatment. And I would say the nurse is still perhaps first and foremost the most important person. The therapy radiographer is often underestimated as a support person. They're seen as a technologist, someone who actually operates X-ray machines, but in fact they're the only speciality in the National Health Service who spend all of their days just treating cancer patients. And often they're very good at supporting patients, giving them advice. And I'm quite touched with the stream of letters I get all the time, and the Chief Executive gets all the time, from our patients, especially my old prostate chaps, who really appreciate the efforts of the radiographers.
Who else in the team, even if they're not working on the oncology wards necessarily?
Well, even the secretaries. I've had wonderful secretaries over the years who are very good at detecting, for instance, if someone's upset, an experienced secretary will say to me, I think you should be bringing Mrs. So-and-so's appointment forward because she phoned me the other day.
Their role is underestimated, isn't it? But they're often the front line first contact for many patients who want to get in touch.
And a shrewd secretary can realise, when you have a good working relationship with them, they say, I think this patient should come back next week. You say, yeah, book them in for next week. And they smile and say, I've already done that.
One thing I've picked up on from other centres, particularly the Scandinavian model in Denmark, Finland, Sweden, is the idea of rehabilitation oncology as a subspecialty. But in principle, the idea is not to finish looking after the patient the moment their acute treatment is over, but follow up the patient and try to get them back to doing more things as possible. But I haven't seen that really take off in the UK very much yet.
I think it's a very important point, and I'm sure you're right, it's something which we should be doing, and it's something we've ignored, and often sometimes our advice has been counterproductive. For instance, a friend of mine, Phyllis Windsor, in Dundee, took two groups of 60 men with prostate cancer getting radiotherapy. 60 of them should give the conventional advice, which is, if you're tired during radiotherapy, put your feet up and rest. The other group were told, no, take graded exercise, and they were tested on a treadmill before the radiotherapy and after the radiotherapy and later on, and the chaps who were taking graded exercise during the treatment of battle fatigue did better. So some of our advice, like, yeah, if you feel tired, rest, may be wrong. And I'm sure that this idea of rehabilitation has got a big application in the health service. We just haven't done it yet. But your point is valid and we should be doing it.
I think one of the catches there is sometimes we can give even advice to do more, but the patient can't necessarily follow the advice on their own. They may or may not be supported by their family in that regard. But if they have a mentor or almost a personal trainer, that can actually be helpful, but it's expensive. To do that's expensive.
It's very expensive. One of the deficiencies of the health service is lack of physiotherapy. And it's one of the things that our managers, I'm particularly talking at Leicester, don't appreciate the role of the physiotherapist. For instance, we may use physiotherapists when people have weakness of their legs, which then recovers, to try and get the patient up and walking. But getting physiotherapy in the community is virtually impossible. And I think our physiotherapists are great, but I don't think our managers rate them. And if you're talking about rehabilitation, you could almost argue it's the natural role of the physiotherapist.
Yes, that's a very, very good suggestion. Another area which I've found slightly overlooked, I'm just interested in your opinion, is cognitive change and memory problems. And there's this whole idea now of chemo brain, which is a slightly horrible American term, but it does at least draw attention to the fact that we've got another domain of problems that we perhaps haven't been attending to. And one of the issues is we don't know whose responsibility that is to look after memory and concentration problems. But do you think that's a valid problem that you're seeing more nowadays?
I think it's a valid problem in two areas. The first is in lung cancer particularly, because there is good evidence that patients with lung cancer do seem to have a lack of memory and concentration. Some of this may be due to chemotherapy, but people who've studied this closely show the changes can be there before the chemotherapy, and it seems to be secondary to lung cancer itself. The second area that I see is men who receive hormone treatment for their prostate cancer, and the hormone treatment works by stopping them making the male hormone testosterone. And some men's brains just don't work without testosterone. Their concentration lags, their memories becomes poor, and it's undoubtedly a real feature. I particularly remember a very high-powered director of human resources couldn't function with testosterone deprivation. When we stopped it, he was back to where the chap he was. And it's something that I see, even just minor degrees in relatively elderly men. And I don't know how we get around the problem, because we've shown a very marked improvement in 10-year survival by combining hormone deprivation and radiotherapy. But undoubtedly there's a price to be paid, and it's underestimated by many doctors.
Yes, I'm sure you're right. Now you've got vast experience, both of the research literature and personal experience of seeing many patients. What do you think are the gaps, and where do you think we should be focusing our resources, and how do we need to improve in the field of oncology in general?
The University of Leicester identified two key areas. The first is lung cancer, and the second is pancreas cancer. Lung cancer is important, firstly, because it's by and large preventable. The overall survival for lung cancer across the board is only about 10 to 15%, which is pretty poor. If you think about breast cancer, 90%. One of the reasons may well be that there's been an element of almost blame, well, they're smokers, what else do you expect? Certainly the university is putting a tremendous effort into research into both treating lung cancer and also detecting it early. The other really bad cancer is pancreas cancer, where the results are even worse, about a 5% 5-year survival, in spite of the fact that we have some of the best pancreas surgeons in the world in Leicester, and great efforts are being made to improve the prognosis for cancer of pancreas. There are very few other tumours which only have a 5% 5-year survival. Even some of the brain tumours that 10 years ago had a 0% 5-year survival now have 10-15%.
Is that because those cancers are spreading very early, or even before they present? Or is it because something cellular is more toxic about those forms of cancer?
I think both. The first is some of these lung cancers do grow quickly, but often their early symptoms are masked. For instance, lung cancers often develop in people who've already got pre-existing chest disease. So if their cough worsens, they don't get terribly upset. If they become more short of breath, well, it's my bronchitis playing up, or so on. And it's only because they start coughing up blood, for instance, they go and see a doctor. They may have had a cough for 6 months, and it's only when the blood appears that they think, perhaps I should see my doctor. So diagnosis is delayed, but many of these cancers are particularly resistant to chemotherapy. Pancreas cancer particularly, the response rate to chemotherapy for pancreas cancer is only about 20%, where if one says takes ovary cancer, 70% of patients will respond well to chemotherapy. Yet
there's always the option of surgery, so why isn't surgery more successful?
The trouble is, in pancreas there's an awful lot of vital structures around the pancreas. It's situated close to the spine, it's close to the liver, close to the stomach, and it often spreads locally outside the pancreas to involve these structures. And even the efforts of the highly skilled surgeons in the general hospital, they find they just cannot surgically remove it, and it also quickly spreads to the liver. It's a particularly awkward customer.
Let me come on to a new topic, which is the understanding of cancer in the general population and the idea of what causes cancer. I heard you say earlier about viral causes for certain cancers, and I think that it will surprise some people, because some people don't think of cancer as being something that a virus can cause. But then again, most people don't really know what causes cancer. It's an area which is replete with a lot of assumptions. What would you say about this complex area?
The first thing is we don't know in many patients' cases what caused their cancer. In certain cases we do, in the majority we don't. With regard to what the public feel about cancer, we carried out a recent study in Leicester to find out about public knowledge of cancer, and it was really slightly depressing in its way, because it turned up quite a few old chestnuts that I thought had been disproved long ago. For instance, almost half the population of Leicester thinks cancer can be caused by stress, which is not true. 25% think it can be caused by an injury, which is very uncommon, that an injury leads to cancer. Things like lack of exercise, obesity, aren't rated by people in Leicester as a factor that leads to cancer. Smoking is recognised as a cause for cancer. And I think increasingly, though, viruses are recognised by people in Leicester, partially because school kids are now being vaccinated against cervix cancer. And I would think in 20, 30 years' time it will pay dividends. And interestingly, the same vaccine may protect against head and neck cancer, as we're recognising that more and more cases of, say, cancers in the throat, particularly, are caused by a similar virus.
Of course, of those causes, the ones that are reversible are those perhaps that are of particular interest, because it implies we can do something about it. So are there ways the population as a whole can prevent or lower their risk of cancer?
Well, I think the first thing is preventable cancer is terribly important. Like the very fact that the human papillomavirus has been firmly linked to some forms of throat cancer and cervix cancer is terribly important because they'll be vaccinated against it. The cancer that's equally preventable is most cases of lung cancer. The incidence of lung cancer has been dropping for 20 years now in men, not women, but been dropping for 20 years in men because it's preventable. Equally so, some industrial cancers. There's a cancer of the lining of the lung caused by asbestos. It's relatively common in this area because a lot of asbestos was used, for instance, in the locomotive works in Derby and this sort of thing. And there's often a 30 to 40 year interval between the men being exposed and the cancer appearing. So although many of these forms of asbestos have been banned and asbestos exposure has been stopped, we still see lots of cases of asbestos-induced cancer. And it'll be another 30 or so years before we stop seeing these cases.
There's also importance of just diet, exercise, and general lifestyle, which
I think they're terribly important.
They're hard to quantify, but always come up as risk factors.
Diet is important in that there's no doubt that increased amounts of fruit and vegetables in the diet make a difference. For instance, I recently learnt that the incidence of the cancer behind the nose, Nasopharynx cancer, has dropped by half in Hong Kong, and this is attributed to, in fact, the improved diet of the people in Hong Kong. It helps them to resist the EB virus. It's very difficult. The Cancer Research Use campaign have dropped their 5 portions slogan, but I still think a diet rich in fruit and vegetables is terribly important. We know that overindulgence of alcohol can lead to cancer. We know that people who are overweight and lack exercise have a higher risk of getting cancer. And a lot of patients that I see, you can tell from their lifestyle, they come in with 10 or 15 drugs for treating their high blood pressure, their heart disease, their problems with their bowels and so on. And these people are basically unfit, and the cancer is just almost the icing on the cake. On the other hand, I see old chaps of 75 who come with prostate cancer, and you say to them, "Are you on any tablets or medicines?" And they say no, and you think, yeah, he's got a good chance of making it to 90. He's certainly worth radical treatment.
I've got a feeling that the NHS, and I'm sure other healthcare organisations, haven't really taken on board these so-called lifestyle factors. We often gave them like passing significance, but yet they crop up with so many medical conditions. It seems like we should have more structured ways of helping people with certain so-called lifestyle problems.
I'm sure you're right. I only wish I could argue with you, because when we did our study looking at the knowledge of people in Leicester of what causes cancer, it was quite depressing in that it was not that different to one done 50 years previously in Leeds by a lady called Cartwright. And you think, gee, we're 50 years on and our cancer education programme hasn't taken us terribly further forward. The major difference between our study and the one in Leeds 50 years ago was that people did appreciate the importance of smoking. But it was still, these other lifestyle factors weren't appreciated, and I think Cancer Research UK isn't getting its message across.
Let me take you in another direction from the perspective of a newly diagnosed patient now, on a kind of more personal level. Somebody's just been told they've got cancer and they're about to start treatment. They don't really know what to expect. Is there any advice in general terms you would give?
I think the main thing is about patients is to explore how much information they want. Ask them, what do you want to know, how much information, and one can often do it by initially indirect questions to try and establish how much patients want to know. Encourage patients to ask questions, ask as little or as much as they want. In some patients it's often easier to show them their scans because a picture's worth 1,000 words. Our therapy radiographers are very good. I'm consistently impressed by how much they can explain to patients while they're on treatment, and really ask it non-medical staff questions, appropriate non-medical staff like nurses and therapy radiographers who will do their best to answer the questions. And the advice I often give to patients when they come to a clinic is prepare their questions in advance. There's nothing wrong having a shopping list and bring out the shopping list and saying, I've got 6 questions to ask you, and go down the shopping list. It's a very efficient way, in fact, of answering the patient's problems.
So you wouldn't mind if somebody slightly put you on the spot in the clinic with a direct question?
Not at all. In fact, we possibly encourage it, because it's actually quite an efficient way. If, say, I've got 6 questions for you, and in fact in a busy clinic, one can often get rid of the 6 questions in 5 minutes, rather than go around the houses trying to find out what the patient wants to know. If there was one factor that I do hear as a slight negative, it's not in relation to oncology, it's general in the NHS, I guess, it's the time factor, that patients sometimes feel there isn't enough time during sessions, clinics, it's a busy environments. Is there anything you can say, even if you're talking now to the managers or your colleagues? The answer is, of course, they're right. They're absolutely right. We don't give patients enough time. In my clinic, patients are allocated half an hour for a new patient talk, which is nowhere near enough. Our follow-up intervals can be either 10 or 15 minutes, which again is not enough. In the continent, anyone would get at least an hour for first visit. So I'm acutely conscious, yes, the patients aren't given enough time. Over the years, I've tried to build up skills by which you can communicate rapidly and efficiently, rather like the shopping list. That can be dealt with in 5 minutes. But yes, I think it is a fault in our system. Perhaps the biggest single fault is we don't give the patients enough time.
Let me ask you one last question now, and that's about research. You've done a tremendous amount of research in lots of areas. What research would you like to do if there was a direction, of travel that would produce a result?
My own research program has been fairly broad-based. I've done research in both radiotherapy and chemotherapy, plus psychological support. I'm very interested at the moment in the genetic areas, particularly a small number of patients develop serious late radiation complications where the vast majority don't. Why is that? We've got an international consortium together which Leicester plays a very big role in looking at this problem, because millions of people throughout the world get radiotherapy every year. I think the long-term research I would like to have is personalised medicine and try and tailor-make treatments more, either in the form of surgery, chemotherapy or radiotherapy for the individual patient, and actually try and get rid of this lottery where we say, well, you've got a 70% chance of surviving and a 30% chance you'll die, and actually refining that further by saying, yes, we can identify factors in your tumour and treatments that will guarantee you success, or I'm terribly sorry, this treatment isn't going to work.
Yeah. I said that was the last question, but I just want to ask you this closing question, which is, given all your experience, how much have things changed from when you started work for the patients, who were facing their new diagnosis then, to that same equivalent type of patient facing their new diagnosis now in 2013?
An enormous change. We still don't give the patients enough time, no argument, but patients are given more time. There's much more emphasis on communication. There's much more emphasis on treating the patient as a person, and generally, rather than just treating their cancer. When I started, there was tremendous emphasis on, he's got lung cancer, let's treat his lung cancer. and rather seeing the man with the lung cancer. And I think that's probably been the biggest change of all.
That's such a key factor, and I really appreciate you saying that. So on behalf of myself and the viewers watching this, I'd like to thank you for spending this really valuable time explaining about cancer, the treatment and etiology. So thanks very much.
Thank you.